Thank you all and welcome. It's great to see so many of you joining the session today. So just a brief outline of our session. I'm going to introduce and present some early findings from the study that we've done in the strategy unit. Please, as I'm talking, as my facilitators are sharing information, please feel free to use the chat box to ask questions. We'll try and pick some of those up later, and where we can, we'll respond to them in the chat box. And then we're going to do a bit of an interactive bit, and don't worry, I don't want to lose any of you, so there's no breakout rooms, but we will be using a Jamboard session, and Mahmouda will post that at the time, and we'll be using that to get some ideas about where we go next. And then at the end, time and technology permitting, we'll try and do a little poll and do some response to some questions and wrap up as well. So hopefully we've got enough time to cover all of that. Okay, so I'm going to start off with a little bit of context that introduces the reason why we did this work and some of our findings and how to interpret them. And I guess I'd start with why health inequalities matter to us in the strategy unit. And you have seen that within this festival, we have dedicated a whole week to health inequalities. We started on Monday with Karen discussing the gender imbalance in terms of equity and access and outcomes to health services and what it means for us as women working within the NHS as well. On Tuesday, Fraser did a session around homelessness and vulnerable populations. Yesterday, we had a wonderful session with music that Peter chaired, and that was to do with mental health and young people and children's health, mental health, sorry. And today's the ethnicity one. So we've been doing some work around ethnicity and inequalities. Some of you might have seen that we have a paper that's been published, and it's on our website at the moment, which looks at access, so the barriers to access for women from ethnic minority groups who are trying to access perinatal mental health services and the inequalities that exist there. And when, I guess this piece of work is personal. When the data first started coming out back in April about the disproportionate impact of the COVID morbidity and mortality on people from ethnic minority groups. And I saw that data back in April and thought, well, this could be my father, this could be my uncle, this could be my husband even, in fact. So what does it, that there is a huge amount of risk for people that I know. And then also I was looking at the narrative about the explanation about why some of these things happen. And it really frustrated me, and it's very similar to this quote that comes from one of the interviewees, who says that it's about how the different ethnic groups are grouped together and the assumptions that are made on our behalf. So some of this work was around challenging some of that narrative, and also a lot of the work that was being done was very much top down. So it looked like it was, it was around looking at people's, looking at the big data, looking at the assumptions, the kind of narrative, the explanations from that level, but actually nobody was really asking people who lived within these communities, people who are part of those communities. So we thought, let's do a piece of work that's very much bottom up, and let's collect the stories of actually what does it feel like to live in these communities and live through the experience of having COVID. So it started there. It just started as a basis of collecting some of those stories to try and give an alternative narrative about what was happening elsewhere. And we were thinking nationally, but actually some of this narrative is emerging internationally as well. Okay, so when it comes to looking at ethnicity data and taking a very UK-based perspective, we tend to use in public sector the acronym BAME. And most of us who are attributed as BAME do not identify with that acronym. And there's a good piece of work that's been done by people who work within the arts, and they pulled together, you know, a survey and actually a virtual workshop where they defined, and this website gives you a link to that, but what actually, you know, what are the right terminology to use. So whilst this session is not about, you know, identity and how people identify themselves and the terminology for that, it's really important to remember when we're looking at data and when we're interpreting data, how we group the different ethnic groups, because you know, as our interviewees and us as interviewers found that actually nobody wants to be reduced to an acronym, and that there is not one size fits all approach when we're talking about what we do with our populations. Okay, so I'm going to give you a bit of a kind of a teeny bit of a history kind of example, and also the South Asian perspective, which is what I identify as. So I come from, and now I've got this, I think I can get my laser pointer. So we in the UK, we have, when we're filling in ethnicity data, and I know there's a national, there's a kind of a discussion today on the news around recording of ethnicity data on death certificates, but actually in the UK, we've been recording data around ethnicity for other use, other purposes for a long time. And most of these are, you know, for age, you can identify as Asian, and then you get a breakdown into Indian, Pakistani, Bangladeshi, and other Asian. And equally for Black, for people who identify as Black, you can break it down by Black African, Black Caribbean, or Black other. So just wanted to give you some information around how people identify themselves as part of that. So if I think about South Asia, and that's one of the main labels that I use, so South Asian heritage, if you ask the question about how we came to be in the UK and how there's a sizable population, we have to go back almost 150, 200 years to the British colonization of India, the subcontinent at the time. And post-slavery, there was a need for labourers in the Caribbean, in kind of South Africa, and so what happened was there was migration. The indentured labourers came and went from South Asia to Kenya, Uganda, to East Africa, and also to South Africa, but also to the West Indies. And then post-partition, so this is 1947 when the British left, there was a split up of India and Pakistan was East Pakistan, which is now Bangladesh, and then there was West Pakistan, which is now Pakistan. And so there was a post partition, there was a movement, a second movement of economic migrants, immigrants, which is part of so my grandfather and my father would have come as part of that. But also there's something that's very different. So there's something that's labeled as twice migrants. So these people, those people who moved to Kenya, Uganda, Tanzania, some of these would have been economic migrants, but they were also part of the indentured labourers. They also came to the UK. So what's happened, I mean, the reason I wanted to explain this is that what's happened is that when we look at our communities in the UK, and I'm here, I'm very much referring to South Asian communities, there's a difference in types of roots that people came from, and that's had an impact on how the economic background, the educational backgrounds, and also the kind of the religious associations that people have with that. So it's really important to consider some of this history in terms of how people identify themselves and the way that they live their lives. Okay. Oops, I can't move to the next slide. All right, so when it comes to migration and ethnic diverse communities in the UK. Experience of poor experience of public services is very well known, and this book, which was just published earlier in this year, is available as an e-book, and I think Richard's going to put that in the chat box. Gives a really good comprehensive understanding of actually the different public service experiences that people have. And what they point out is that people have, whilst we've collected all the data, we've understood that people from ethnic minority groups have poor experience of public sector services. No one moves beyond that admiration of the problem to looking at what the solution could be and actually taking action and doing and moving away from the narrative that's just about all this cultural consideration that we should think about, and it literally starts and stops at that point. Okay, so that's a bit of context just to introduce the work and the setting in the UK, and then just going to move on to our findings in terms of what we actually did. So just a first slide on who we spoke to. So as I said, our main ambition was to collect the stories. We just wanted to understand what people like us, their experience of COVID, whether what we were feeling in terms of our families, in terms of our communities, was that something that everybody else was doing and was also feeling, or were we just seeing a very siloed understanding, and how much did this fit in with the national narrative? So we spoke to 11 people in the end as part of the first wave. We stopped at a certain point because it looked like wave 1 was finishing and wave 2 was starting, and actually there was a little bit of despondency in terms of trying to say, okay, the overlap between this work and what was happening with Public Health England work, and also what was happening with Black Lives Matter movement. So this all had a little bit of an impact in how we were recruiting. In the end, so we interviewed people from June over to August. There was mainly South Asian, but we had some participants who identified as Black and also as Middle Eastern. Good mix of women and men, but actually we asked people to speak on behalf of their household, and on occasion there were other members of the family who were also participated in the conversation. Most people, so we had no set rules in terms of occupations or anything like that. Once the data started emerging that it was specific occupations, we were trying to sample so that we could get those occupations covered. But actually, when we talked to people, we found out that there were different occupations within the household. So surprisingly for us, but maybe not surprisingly when we think about the representation of Asian and Black people in public sector, actually we found a lot of people. So I think 5 out of our 11 interviews actually worked in NHS, only 2 of which were clinicians. We went for widespread, so we asked for participation across the country, and we got a good spread, mainly urban areas that people were kind of lived in, resided in. Okay, so for all of these we've used pseudonyms, just to make that clear. So the main themes that emerged as out of our findings, and this is the kind of the qualitative kind of extraction of themes, and we'll go into some of these in a bit. So mainly people talked about their aspect of their household, their occupation, how that affected their identification with their community. And then, of course, what the main thing that we were interested in, because we sampled for people who had actually had COVID, whether it was confirmed or not, but had high level of the right types of symptoms, basically. And their use of health services and how they felt about the national narrative and the policy and guidelines that were coming through. So the ones in black and gold, black and orange reflect the main themes, and then they've got the sub-themes as part of that, which I'll just go into. So first of all, families. So this is about the individual families and their households. So this probably the first point is probably very similar to everybody else. You know, this is very little to do with ethnicity. So people range in their ability to manage infection control at home. So remember, most of these we're talking about experiences very early on in the pandemic, and a lot of the people that we interviewed had symptoms before lockdown happened. But they were trying to control how they manage their risk of getting infected. So most of them, a lot of people believe that it was just a bit of flu and they weren't too worried about it until it actually happened. There were other people on the other extreme end, and they were very anxious, so everything got disinfected. Grace on the right hand side, you can see the quotes from some of our interviewees, and you know, she talks about her husband having to change his clothes every time he came back from outside, and he was and this is just some of the things that they put in place. What was different is the ability to isolate in the household when symptomatic. So there is a little, there is something around that confirms the national narrative around the number of people in the household and whether people were able to kind of be in different rooms or actually take the necessary procedures once they had the infection to prevent other family members from catching it. The other thing that was different was around the ability to follow the rules around social distancing and and the blurring of household boundaries. So this is mainly to do with how, and I'm talking probably more specifically for South Asian families, the ability to make decisions that's just relevant to your own household. And I can speak from my own experience here, is where the decision I make as part of my household, and we're a family of 3, I have a 14-year-old son, but actually the decisions that we make as a family impact on my mother-in-law as well, because and impact on my in-laws as well. So the decision about how we follow social distancing guidelines, how we socially distance, is much more than that individual family as well. And what we found time and time again, and this was a little bit surprising, that actually there was a lot of tension that was created within family environments because everybody was different in how they wanted to interpret the guidelines and how we do things. This thing that Bilkis says about actually we've been called the COVID police because they, you know, she as an individual felt that she was instructing other family members about how to behave and what to do. So there was a lot of tension around that. The other thing that we find within South Asian families as well, again, is that there's an expectation of poor health. So the national narrative is around, everybody has comorbidities, everybody's sick. And that actually happens much earlier. So people, when they were talking about their parents, or they were talking about, when they talk about their parents, they could just be in their 60s, but they would refer to them as being very elderly in some cases. So all elderly, very elderly. So it's this perspective that we have, that people who are of a certain age, because they're of a certain age, they will have. It's inevitable that they will have illnesses. So then moving on to occupation, and as I said, most people had symptoms or were starting to show symptoms as lockdown happened. And the majority of people would attribute their primary route of infection in their household to their occupation or to another adult in the household. There were some instances of people saying that it was through their children, and they felt that was where they felt that their exposure came from. Remember, at this time we were really testing for people who had symptoms if they were mild. So Fatima talks about her daughter, and so she's got a grown-up adult daughter who's an engineering apprentice, and she was in the office, and everybody got back but was sent back home. and then the whole family developed symptoms as a result of that. What we did expect when we were asked a question about occupation and the risk for COVID is how many people then actually went on and described kind of more kind of microaggressions within working environments. And Jamila goes as far as to say that she felt that was racism. So Jamila is the who had symptoms that we now recognise to be long COVID. And she works in the NHS in an admin position, and she felt that she was she had a very bad experience in terms of how her colleagues treated her after she came back, and having those symptoms continuously, and whether there was a lack of belief, and she attributed to it the fact that she was Asian. For her, that was quite a key thing. But others went on to say that that the lack of ethnic representation at senior levels was also a part of the challenge that they had. When it comes to community, so there's the individual household, the occupation that individuals had, but then it goes wider, and people talked about the community that they lived in, and what lockdown and having COVID symptoms meant for that in that aspect. There was a whole range. So the people that we interviewed came from all walks and classes of life. So, you know, they described their residential areas were in terms of affluence. So people talked about being so in such an affluent area that when they clapped for NHS colleagues, you could hear it. And then others talked about the level of deprivation that they had, and the open drug dealing that went on in their community. And yet they felt safe because it was their community. So it's an interesting reflection there. Most talked about the religion that they belonged to and how that was important in terms of where they lived, and that people choose to live there because of that sense of belonging, or the safety, or the access to things like mosques. And that's a really important thing, the choice. People are making a choice, and then reading and I think it was in that first quote that I shared earlier, that where people, that actually it's very much a choice of where people live, that they, and when they read the national narrative around these are deprived areas, it's not how they perceive where they live. It's not how they identify their community. For most of them, regardless of where they live, they felt that it was a good opportunity to confirm community values, and especially in places which were more diverse in terms of ethnic mix, they felt good about being able to support other members of their community, and you know, regardless of what ethnicity they had, and to be able to do all the things that we all tried to do for our communities at the time. But for others, where they found that they were at odds with how they thought mask wearing, for instance, when it wasn't mandatory, distancing in grocery shops and things like that, those really tested some of those community values that they had as well. When it came to community, there's a sense of how to handle the COVID crisis. So there was some disbelief at the beginning, I think, and that went beyond the individual household, but actually wider. As Qasim says here, there's a sense of fatalism in some community aspects. It's about, well, this, you know, God is going to protect us. If this is going to happen to us, then it will. You know, we can't really do anything about it. So that sense of almost coping mechanism was very strong. I think my own reflections of seeing how things are working out for wave 2, I think that's becoming even more of a kind of a central to how people are interpreting and the fatigue that's setting in. Then there was also in our kind of professional settings, you know, we've often talked about people. Do you know anyone who's had COVID? But for me, I knew that the second wave was starting when I started getting messages from my father around, you know, so my dad on the WhatsApp group shares the mosque death messages. So people who are passing away. So there's an alert that goes out to the community, and my dad, who lives up in the north in Bolton, will share these with me, with the family WhatsApp group. And so I completely understand what Dawood means when he says that every single day you knew of someone who was passing away, someone that, you know, someone that's close to you, someone that's in the community, and you're thinking about how, you know, how much more of this can you take? So so Dawood was the only one who had a direct bereavement in the household, but most of the people that we interviewed could actually talk about the relentlessness of the bad news, and how overwhelming and how much they had to switch off, and the impact on that on their kind of almost their well-being as well. Oops. Before I go on to the kind of the findings, the qualitative findings, I just wanted to bring, in terms of access to health use, just wanted to bring your attention to a piece of work that colleagues in the strategy unit have done, and this is Stephen Wyatt's work. And some of you who attended, I think, the first week sessions, you'll have seen that he shared a slide which showed how emergence, any attendance by ethnicity, any attendance fell everywhere nationally, as we all know, but also it fell by ethnic groups as well. So it was more significant in terms of the decrease in African, in Black and South Asian, Black and South Asian groups. But what I asked him for was whether he had a breakdown of the data, and he shared this with me, which I'm showing here, which shows that whether it was for injury-related any attendance or for illnesses, for the same period in 2019 and 2020. So we're comparing the kind of the phase 1 of the pandemic to this time last year, to the same time last year. Not only did it vary by ethnicity, but actually there was within ethnicity kind of fault as well. So, and it was most significant in the Chinese group, which, as you'll be very aware, I've not spoken about at all. And so this is it's a hard to reach group in terms of doing this type of research, probably because, you know, Mahmoud and I were involved in this work, and you know, we could use our own personal networks and actually do a bit more work in terms of accessing communities that identify as Indian, Pakistani, Bangladeshi, but actually this Chinese group is much more difficult to reach, and actually the data shows that there's something happening here, which is very different to others. So just wanted to bring your attention to that and to try and say, okay, there's something else that we need to do. We assume this is something to do with the high levels of racial attacks that went on at the very beginning of the pandemic, because of the origin of the virus. Okay, so what did our interviewees do? What did the people that we spoke to do in terms of accessing the advice from and seeking support from health services? So almost surprising is the lengths that people went to use their own personal networks to seek professional advice. So this could be, my neighbour's a doctor, my son's a doctor, works in the NHS 111, and being able to, you know, access advice there. Mahmoud and I have experiences. We're not clinical, but, you know, people will, you know, our family members will ask us because we're the closest that they know in terms of people who work in the NHS. So within South Asian communities, there is, people will use the people that they know to ask for advice on what to do. Where people work in the NHS services, they were able to go to more extreme. So Ali described actually knowing someone who is a director at one of in the hospital that he works with, and they were able to offer a respiratory consultant for a phone advice and for his son. So there was various different examples that were given of this. Those who tried to use NHS 111 were very, very dismissive of the advice that was given to them, and there was a lot of going back and forth with the GP to try and make some sense. In the end, most people just kind of dismissed it and looked at advice given by friends and family. So they treated it symptomatically, lots by herbal remedies and things like that as well, to be able to treat the symptoms. So of course, this was when it was, we would assume it to be mild symptoms. Where we found nationally, and the strategy has done another piece of work looking at system-based response to COVID, another qualitative piece of work where we also looked at patient accounts. And patient accounts suggest that people stopped going to hospitals, or people stopped using healthcare services because they were scared, which was the same in this piece of work. But what we found was that the fear was slightly different. It was more nuanced. It was nuanced because people were worried about suffering alone. So the reason that they stopped going to hospital because they were worried about being admitted. They were worried about, and if they were admitted, that meant that they would be alone. There would be no family member that could come with them, and they would prefer that they would suffer almost at home rather than going into hospital. And there was also some concern about the type of treatment and the safety. When you see the data that most people who go to hospital and who die, who have complications, are who look like you, then there's a fear of saying, okay, that's going to happen to me just because I am Asian, just because I am black. So there was that. Ishan, who was the doctor a consultant that we interviewed, who had COVID, who had very severe COVID, refused to go to the hospitals because he knew at the time that they were doing procedures which he felt was going to put him further at risk. So he turned down and he managed his symptoms at home, very severe symptoms, with help from his colleagues who came home to do some of his treatment. Those who used urgent care services, who were admitted to hospital, reported good experiences of the care that they received. But there's quite a lot of challenges in terms of the mental health and well-being anxieties that are coming up post recovery. And as I said, one of the people that we interviewed does seem to have long COVID challenges. And then the mental health anxiety. So even if you just had very mild symptoms, people were aware of other people in the household who were starting to face kind of anxiety and pain issues that were there beforehand as well. Many knew of people in the family, as I described earlier, or in the wider community who died from COVID. So in our with Dawood's story, where he lost his father, and he comes from a large family, and the bit in his account, the bit that resonates, the bit that's really stark and really painful to hear and read, is where he explains the funeral process and how cold and clinical that was. And how the bereavement. So with Muslim families, we tend to it's a very social grieving process. The days leading up to the death, if the death is going to happen at home, or at the time of the death, the days after death, the funeral, weeks after the funeral. There's a lot of social interaction that happens, and none of this was possible. And so there's quite some trauma associated with that. Okay, so last slide in terms of the national policy. I think as we all know, as we can all individually identify with, most people felt that lockdown was too little, too late, and that the government had to capitalise on what it needed to do, and that resulted in people like them dying, and so that was quite a difficult thing to acknowledge. The guidance, the briefings, and especially when in August, when the kind of lockdown and the guidelines started changing, as we know, the north-south divide now with what's happening in Greater Manchester, all of these things just completely just switch people off. And whereas people, whether you would have had adherence to social distancing rules, people were then, starting to make their own rules in terms of how they handle this. And a lot of anger, frustration, and we go back to the first, the first quote that I put up, that some of this was already known. Some of this was already known and not acted on, and there was so much, quite a bit of anger and frustration. And for me, doing some of these interviews and listening to those accounts or reading some of those accounts afterwards, that was quite a shocking thing, because it was unprompted. We did ask for that. We did ask those questions, but actually in people's accounts, this is what they talked about. Okay, that is it from me. I'm going to hand over to my colleague Mahmouda. And what we're going to do is we're going to do a bit of an interactive Jamboarding session. So she'll put the link on. And what we just want to understand is, based on your own individual experiences, the position that you have in your professional role, what can we do further? From what you've heard, what can we do further? What other aspects of this inequalities and ethnicity, related inequalities specifically, what can we do to explore it further using qualitative, quantitative, mixed methods techniques? And then for decision makers within this session, what can we do individually in our population level to do that? Mahmouda, can I switch hand over to you?
Yeah, brilliant. Thanks, Abby. Hi, everybody. I hope you've enjoyed listening to what Abby was just going through and sharing our findings of our study. If you've got any questions about any of the work that we've done, please post them in the chat box. And then myself, Abby and Richard are available to obviously answer any of those questions. So I'll just be setting up this in the background, so feel free to ask away in the chat room. Whilst you're doing that, I'll explain what we're about to do next, which is I'm going to put up a link to a Jamboard, which is a link to a Google open access, open shareable link, which just has a whiteboard basically, where we posted these two questions that Abby had on the presentation up just a second ago. So those two questions are, what next in terms of what should we explore next, so that we can look at what we might prioritize or focus on, or questions that are still unaddressed. Given that this is not new, this topic isn't new, and there's been various discussions going on over the last few months, we obviously want to know where to take it next. The second question that we've got is all around, what does this actually mean in terms of individual and population level action? So as I just post the link, this will bring up a whiteboard. If everybody can access that, that would be great. You'll notice that on the first sheet, the question is just what next for further exploration. What we're asking you to do is just put your comments, suggestions, questions. That can vary whether it's quantitative, qualitative, mixed methods, whether it's just a topic of interest that you think it needs further exploration, and just pop that on a post-it. The post-its are available on the left-hand side toolbar, so you can just select any one of those and put in your comments, and then they'll go into the whiteboard. We'll come on to the second sheet in a little while, so I'm just going to give you a few minutes to sort of pop your suggestions, questions, topic areas on there. And then what we'll do in this sort of background is myself and Richard will sort those out into different categories, and then we'll take a vote on those at the end of the session to see what people are most interested in, and see how we can take those further, really. So if everybody can do that, and then we'll come on, I'll give you a couple of minutes to do that, and we'll come on to the second board. I might just share screen so people can see it as it's being populated as well.
It might, Mahmood, it might be worth pointing out that it's anonymous. You can put what you want. I think we can sort of link it back to people if that helps at all. You can also pick different colours, which is lots of fun.
Yeah, brilliant. You can absolutely do that. Go as creative as you like. So it is anonymous. You'll be given a, okay, maybe not that creative. I see a smiley face popping up, and I'm assuming that's you, Rachel. I'm sure you said you were going to behave on this one.
That was not me. Somebody's going to have to own up to that.
Oh, it's been taken care of.
And please feel free to ask questions.
Okay, there's a little blurry of them now. Richard, I'm hoping you're on top of sorting.
I think it takes a little while to get into thought mode, doesn't it? Well, it does me.
Let's give it a few more moments. There's lots of good stuff. Oh, really great suggestions.
And others can type faster than me as well.
Oh, that's great. Let's see if I can.
Whilst people are thinking, there's a comment in the box in the Jamboard that's quite interesting, and I think someone's pointing out that more needs to be done in terms of looking at the Black ethnic group, and within that broad group of different cultures and religion. And that's one of my kind of almost a request out to all of you who are interested in this. I'd really like people who are interested in looking at ethnicity much more broader, to look at different, the effect on different communities, people who identify with those communities to be part of future work. So please get in touch, because there's I have a limited knowledge and understanding of different communities, and I want to improve that. But I can only do that by making sure that the way that we interpret the data, the way that we access different communities is equitable. So yes, please definitely get in touch.
Okay, we've got quite a few ideas on there. Please obviously continue to add to that if you're still thinking or typing away. That's absolutely fine. We're going to move on to the second question we're looking to explore, which is all about what next then for individual and population level action. So what does that mean for us in the organizations we work with, in the systems we work in the populations that we serve? So we've split it up into two bits, so on an individual level and then on a population level. We're aiming to do a little bit of color coding. So if you can use the yellow post-its for any suggestions you've got on what that means for individual level action, and then a green one for anything that you think that needs looking at from a population level perspective. And then we can arrange in groups, but similar to that, what are your sort of thoughts and what comes next from that perspective?
The comment around use of religious leaders for to target the different communities. I've just seen a really good example again from my dad, who shared something from Bolton. So where the trust, the NHS, the medical director, I think it was, and there was a combined letter from that and the mosque partnership. So it's known as Bolton Community. I can't remember what the acronym is. But BCOM, so they've got a joint letter that they issued and they shared with the community. One pointing out that NHS is open, the services are open, and people should still be accessing health services when they need them. And the second about actually, you know, let's do our bit as a community to do the social distancing and follow the kind of the guidelines to try and mitigate the worst effects of the second wave.
Okay, I think we'll take a look at the suggestions now. So I'm just going to share my screen again. Hopefully everybody can see that. Nods, yeses, yes. Okay, great. We're still doing a bit of organisation around the sort of suggestions. We were going to try and group them up into sort of 5 broad categories because there's so many good ideas on this. Looking at the first one, there's something about sort of more comparative studies, more looking at sort of cultural backgrounds and those sorts of differences, and recognising that the groupings, as Abby alluded to at the very start, are not as straightforward as we initially thought, or might be suggested in some of the literature. The second one where it is all about speaking to people and then really understanding wider their experience, but a real recognition of not trying to sort of overwhelm people. So this is from a very person level, individual level sort of areas that we might want to explore. The third one, interestingly, is about the sort of avoiding generalizations when it comes to how we group people that might be formerly considered BAME or BME or ethnic minority. I've sort of put the need for more action from policymakers, decision makers to acknowledge engagement sessions under that, because that might be a very tailored thing that we need, but it's kind of between 2 and 3, I imagine. 4, we're looking at sort of wider impacts. So that's all about mental health, education, deprivation, all the sort of wider determinants of health when it comes to these individuals that we're talking about. And then 5th is all about sort of engagement with people directly. So whether that's in the communities themselves, but understanding to a greater degree their cultural sort of experience. So I'm just going to put up a poll, and I'm hoping everybody can see this. So the poll I'll put up will have 1 to 5. So again, 1 is looking at the sort of differences, more comparative studies, looking at the different categories. 2 is a much more individual level at people's experiences, their stories. 3 is much more sort of policy level, and also looking at the generalizations made and obviously how that might transpire in some of the sort of communications that are given out to these communities. Number 4 is all about the wider determinants and the other impacts. And 5 is all about engagement and understanding. So I'm just going to launch the poll. I'm not sure if everybody can see it, but if you can vote on what you think is the area that we should focus on next. And if you've got any comments or views on why that should be, then please also add them to the chat box. And we can pick those up as a discussion.
Mahmouda, I might have the same issue as other people in terms of accessing the poll. Is everybody able to access?
If you cannot access the poll, please just put into the chat box what number you think we should address, and we can also pick them up on there.
Ramoda, did you spot that someone in the chat box is asking if you could just go through the options again?
No, I hadn't seen that. Thanks, Peter. I can't see the chat box at all.
Okay.
So number one is all about looking at the sort of differences in how we categorize people and looking at a more comparative study across different countries and other studies that have been done elsewhere. Number two is a much more individual level topic area where we're looking at people's experience and their individual stories and hearing from them directly to gain that deeper understanding. Number three is about addressing the sort of generalizations made and the policies around, the national policies around impacting this group. Number four is all about the wider determinants and impacts on this group. And five is all around engagement, particularly community engagement or hard to reach groups. I think we've got a good number of people voting. I can't see if anybody's voting in the chat box. 5, 4, 3, 2, 1. Okay, I'm just going to share the results. So I'm hoping everybody can see that. So it looks like the results are a lot of people, so 13 votes to number 4, looking at the sort of wider determinants and the impacts on other aspects, how other aspects of impact outcomes and experience for these people. And closely followed by 5, which is all around engagement. And then 2 as well, looking at their sort of individual personal stories. So that's given us lots of food for thought, I think. And if anybody's got any ideas on specifically what questions we have to address under these topics, then we'd love to obviously hear from you. We've got like 30 seconds, haven't we?
I just want to say thank you, everybody. Thank you for joining. We've already started our internal conversations about where we take this piece of work. So the suggestions that you've all put in the Jamboard and the voting will help us clarify that. And as I said earlier, and I know other people have put in the chat box, if you'd like to know more, if you'd like to be part of the work that we do as part of this, please in touch and let's take it from there.